Thank you everybody for joining us in person and for those of you joining us online for our Developing and Managing Successful Projects and Cost Controls. We certainly appreciate your time. We know it's been a very unique it's a very unique industry and a very unique time right now, so we do appreciate your time, and we're very excited to share this information with you today. For the people online, if you have a question, please type it into the chat. We will ask the question here. And also for those of you in the audience, we do have cameras here. We are filming this, so if you have an issue with that, please let us know, and we will not have you on camera. But without further ado, I'd like to introduce our panel here. First up is Paul Brown. He is a Director of Healthcare for us here in our Washington, D.C. office.
And I'm Gary Brett. I'm the Vice President of Cost Estimating for Cumming. I've been with Cumming 17 years. I've been a cost estimator and a quantity surveyor for over 30 years. I started with a full head of hair, so reconciliation really kills you, so I really don't want to do it. So we're going to talk about cost. First, we're going to talk about the cost management tools that we have. Then we're going to talk about the traditional healthcare. Then we're going to talk about continuous estimating, which is a new buzzword in the industry at the moment. It's not really new to estimating, but it's the new buzzword. And then we're going to talk about local market insights, and then I'm going to pass it over to my colleague, Gary, for smart and pandemic-ready designs. And then we're going to have a little bit of Q&A in between mine and Gary's, and then we'll pass it on to Bill and Paul. So as I mentioned, we're going to talk about the tools in the toolbox. The first one is DProfiler, or Destiny Profiler. It's not proprietary software. It's a software out of Texas, and it's prepared by a company there. It's a high-level 3D modeling tool that gives you a detailed cost estimate. So when I say a detailed cost estimate, it's actually a near CD level estimate with the exception of MEP, because MEP is a pretty hard thing to tie down at the conceptual stage. And it is a throwaway model, and I hate saying that to owners because there's all owners in the audience today, but it is a throwaway model, and you're not throwing your money away though, because it's just like a can of Coke. You buy the Coke, you pour the Coke out of the can, and you throw the bottle away. Or one architect said, no, I recycle. Okay, whether you recycle or throw it away, it's gone, right? We're not designers, we're not the architects, we're not the contractor. So you are getting that CD level estimate out of it. The Profiler is very good at the core and shell, but it's not very good at the interiors. So we base the interiors on our historical metrics in our database, which we're going to talk about a little bit later. You can customize it. You can do real-time value engineering with this product. And we're going to look at a little example here. And I'm going to talk about the minimum requirements to put a model together. Well, you need to know the location. You need to know the floor plate. You need to know the floor-to-floor heights, and you need to know the amount of floors. And that's pretty much it. We can put a model together with that, with a lot of assumptions. But if we have the engineer on board, we can ask for the structural elements, and we can ask for whether it's steel, whether it's concrete. And that's pretty much it. The estimator will put a assumptions page at the beginning of the estimate telling you what's going on. And as you can see here, this model's just been presented. It looked really easy when we started, but as you can see, it's in the middle of an existing campus. So we have the science with these softwares. Now we need the art. That's the estimator coming in, taking the estimate out, and building the estimate based on real-time delivery and everything in a downtown environment. Then we have the big sister, Destiny Estimator. Well, with Destiny Estimator, you're able to upload models. With Destiny Profiler, you cannot do that. You have to sketch in the 2D model or actually build it yourself. Then we have the option of 2D, which is basically our on-screen takeoff. We do have a database in Destiny Estimator that we prepared, and we can standardize that or modify it to whichever client that we have. It's also good for logging in estimates into your benchmarking, so we can tell an owner what it cost at DProfiler and what it costs at the end of the project, and we can monitor it across the board. We can also put it into our benchmarking so that we've got the benchmarking for the next project. We can also have different disciplines as in MEP or as an exterior skin. That's important these days. Owners want to know how much exterior skins cost for different options. And as we get into continuous estimating, we'll look at that a little bit more. We can also customize it out of Destiny Estimator into an Excel format. We can then localize it and put in historical data. Again, it's the art and the science. And then, as I mentioned earlier, we've got the milestone tracking. Now we're going to look at two graphics, and I always get blown away with the graphic on the right because I started off with a piece of paper and a pencil and a scale ruler, you know? And look where we've got to in 30 years. Wow, it's been 30 years? Wow. Okay, anyway. So we've got all these different sections that we can look at. We can look at the foundations, we can look at the slab on grade, et cetera, et cetera. And then we're going back to the traditional on-screen takeoff that we've got for our 2D model. So then lastly, one of the last tools, and I think it's the most important tool, apart from building the project, I think it's the most important thing in this day and age, which is benchmarking or a cost database. You know, we at Cumming have about 12,000 projects in our cost database. Sorry, 1,200 projects. 12,000 were really good. 1,200 projects in our cost database that we've collected over the last 17 years. And that's where you've got to start, right? You've got to collect the historical database information. Then you've got to work out how you're going to log it into your database. Well, we use the work breakdown structure in CSI, but as I mentioned earlier, or didn't mention earlier, you can, in Destiny Estimator, you can put it into Uniformat and or CSI. And then you got to collect your database and build it with the different silos. You know, I had one client come to me and say, oh, I've got all this information, can you put it into a database? Well, they had the hospital, the site, the central plant, and the offsite all in one tab. And I asked them, well, how much did you pay for your hospital? They said, we don't know. Exactly, so you've got to get it into the silos. You've got to get it into the right silos to people how to put it into the database. So exactly as our circle, you've got to obtain the cost, develop the cost model, utilize the tools that we've already talked about, and then evaluate your cost model. So now we get into the estimating front. So there is a traditional healthcare estimating, that's the way I put it, and we've got 3 steps to it. The first step is conceptual pre-schematic, where we've got the approximate quantities. We've based that off of our D-profiler model, and we've also got our database comparison. And we put our database comparison together for the owner and for the projects outside of the owner's realms. That's why we've got that pretty dedicated healthcare database. And when you get information off of us from, I'm going to pick on Kaiser, if you get information off of us from Kaiser, it comes in confidential. And if we get information off of MedStar, it'll come in confidential. But your projects, you'll be able to understand where they're at. Then, at step 2, traditionally the contractors come in at this stage. It's getting a little bit different at this moment in time. Everybody's trying to push it back into the realms of design development, where it was very few years ago. So we've got this schematic design development. Contractors on board, we're going to do an estimate, they're going to do an estimate. We're going to reconcile, we're going to compare it back to the database. But the important thing now, with the D-profiler and what we've got in schematic design, we can start real target value delivery or target value design at an early stage, which helps you through the rest of the design process. Then there's a red line running up and down the screen there. Everybody asks usually, well, what's the difference between a cost estimator and a cost manager? Well, my description of it is a cost estimator is actually estimating. So in step 2, we're putting an estimate together with the contractor. In step 3, we're doing a peer review. So now we're just a cost manager and looking after the money. So in step 3, Cumming comes in and reviews everything that the GC's given you. We raise red flags if the design has changed or if some of the quantities or costs have changed. And we reconcile again with the contractor. Again, always comparing it back to the database. The important thing is comparing it back to a benchmark or the database that you have. So in summing this up, you know, this process, somebody asked me the other day, well, what type of contract do I need to use this? Any contract, because you're not going to sign the contract until the end of the estimating process. The early involvement of the sub, we can have him in there or we don't have to have him in there. That's why we can move that red line up and down the stages there, and we can still do the work. And then, as I mentioned, it lends itself to target value delivery or target value design, but it also lends itself to lean construction, which is most important. And then this one that everybody came to see today, I think, or a few people did anyway, continuous estimating. What is continuous estimating? Well, we've been doing it all the time, or the contractor has, and now the third-party estimators getting involved as well. Continuous estimating is the effort of regular, frequent updates to the estimate whilst tracking the last update. Now that's important, but there's 2 words that you can roll this all up into: communication and listening. And listening is the most important part in any meeting, right? You've got to listen to understand what's going on in the job. You need to collaborate with the stakeholders to avoid repeated estimates for the entire project. How many times I've done an estimate 3 or 4 times, or we've had updates on the drawings. Oh, give me another update, give me another update. It's annoying for the estimator, and it's annoying for everybody else, right? Because the number's changing all the time. Then we've got the continuous estimating in small batches. And the small batches could be exterior skin. And you may have 9 options for your exterior skin. And what you need to do is get those 9 options down to 1. And we'll talk a little bit more about that later. And then, you know, we want to be proactive. That's the most important thing these days. You got to be proactive. You can't be reactive. By the time you're reactive, it's all gone wrong, right? And you've quickly got to arm the owner, the design team, with the whole total number. So how does this all roll up into a process? Well, the process is those small packages, right? The small packages I mentioned, we've got to get down to 1 option for all of those packages. Could be MEP, could be curtain wall, or glazing, or exterior skin, as I talked about. But you've got to get as quickly as possible down to a full estimated number. That's the most important thing, right? At the early stages, you've got to get down to that full number. But I think with continuous estimating, you're getting a better number, and you're getting better bang for your buck with the estimating that's gone on. Then you've got to reconcile it with the GC once you've got it all together, because things might look a little different. Once you've got all the packages together, you may be over budget, et cetera, et cetera. Then what happens is you go back to more traditional estimating. You may still do some cost studies, because you may not quite be there when the next stages come along. But you go back and you start your continuous peer reviewing of the estimate as you go through. And then lastly, during construction, we can actually review the actual installed work with the preferred production tracking software, or just the old-fashioned way of walking the job and seeing what's there. And then also change orders to ensure accuracy and cost. And then lastly, on the cost estimating front, the localized market insight. So Cumming has a page, Cumming Insight. It gets regularly updated on a quarterly basis from our in-house economics team. We've got understanding market forces, the macros and the micros. We're going to talk about a lot of these, so I'm not going to read them out, but the important ones I've left at the bottom: escalation and market volatility. And that's where we're going to start. So escalation. Every owner asks me, what are we going to see escalation that we had in 2008, 2010, where it went to 0, went to even negative escalation possibly. And we're not going to see it. You know, escalation at the moment, over the last few years, is the highest we've seen in a long time. In 2022, it's starting to ease off. In DC, Maryland, Virginia, we've got the general, and then we've got the healthcare. Usually healthcare is about 0.5 point to 1% over general escalation due to the intricacy of our work. But as you can see there, we're at about 8.5 for this year, 23, 5.6, and then 24, we're back to the normal escalation of about 3 to 4%. And that changes across the country, you know, anywhere between 3 to 5%, you know. So then, what's a good market indicator? Well, it's the ABI index, right, which is the Architectural Billing Index. So the Architectural Billing Index is delivered monthly, and as you can see over at the far side there, we're above the 50 line, which means that we're growing. We're just above it, but we're growing. And as you can see, historically, it's been up and down along that line, but when you see May 2020, there's the big dip for COVID. We're in an uncertain economic condition, you know, and we're expected it to slow. But again, I don't think it's going to fall below that 50 line. So that was nationally. Now this is regionally, and you guys fall within the Northeast here, by the way. There is no Mid-Atlantic, sorry, with the ABI. You're in the Northeast, so you're doing very well. I mean, look at that line. You're up into the 55s nearly, where the rest of the country is tracking around 52. Again, everybody's above, but it looks like here in the Northeast, things are working well. And then construction and labor. Well, we've got 2 here. We've got the DC construction employment, and as you can see, in 2019, again, we were on a real low. Then we spiked in 2020. We were on everybody was unemployed, and then we're coming back down again to low unemployment. And the reason we've got low unemployment is because we've got the highest inflation for 40 years. And when one goes up, the other one goes down. So now we're coming down. Now inflation is slowing, and hopefully we're coming out of the recession. It's my hope that we are. It might steady and then go back into recession again, but hopefully we're coming out. And as you can see, the US employment rate, something similar. You know, we're back to pre-pandemic unemployment statistics, and expected to be an average of 3.7 in 2022. And again, this is tied with the lowest unemployment rates in 1964, since 1969. So I was 4 at that age, so most of you maybe weren't even born, I don't know, but I was 4. Then we get to the labor in the individual labor categories, and you know, we're going to have a shortage of labor still, even though it's at the lowest that we've seen since 1969. There is still a labor shortage. The average age of a journeyman before the pandemic was 42. Now it's 47. And we're seeing the young kids not wanting to go out and get their hands dirty and doing construction. But with modularization, there is a but, with modularization, we're trying to bring some of those kids in, because those kids can work the computers inside the warehouse to be able to make those modular units, to be able to ship them to the site and then be installed. So that's the godsend that we've got. But as you can see, glazing's down at the bottom at 70, and we've got I thought we had an 89, but 87 for Mechanico and 87 for Concrete Works. Concrete Works is probably the worst one at the moment. And then materials. Everybody asks, what's the supply chain doing? What are materials doing? Well, concretes have all gone up. I'm not going to read through them all. You've got the precessed concrete products at the top, but as you look down, all the concrete products, they're all there. And then when we go down to the copper and aluminum, it's on a low at the minute, but next month it could be bouncing back into a high. Copper and aluminum go up and down like the proverbial yo-yo. Steel is in there still in the middle of the pack, but as you can see, pre-stressed concrete products way up there. Then lastly, we talked about the supply chain a little bit. The last time I presented this, we had about 60 cargo ships in the port of LA. I'm from Los Angeles. We had about 60 cargo ships there, and I think there was probably about 40 in the port of Baltimore. It's getting better. The supply chain seems to be getting better. All the products, we've got toilet roll in the supermarkets now. You know, all the products seem to be coming back, but there is still a lag. You can see before COVID, it was 3 to 4 weeks. Now it's 3 to 4 months, 4 to 5 months. And even for some of the Mechanico, and Gary, you can chime in here, the Mechanico at switchgear and so on.
One of the biggest challenge now
Yep.
in terms of delivery that we have.
So generators, 18 months, yeah. And it's slowing your project down or actually stopping your project. So you got to make sure as owners, as project managers, that you're looking at this and pre-ordering in a timely manner and getting some funding from the CFO to be able to get these things ordered. And for the future, we don't see any change in the near future. Hopefully in the future, then we can see something changing. But if we get another Ian sweeping through Florida, you know, gypsum boards already at 5 to 6 weeks. I thought all the gypsum board was going to go to Florida in the last couple of weeks. We haven't seen anything moving that way. But as you can see, long wait times, and that's going to affect your project. So any questions at this point?
So is that productivity, material shortages? I mean, what's at the root of?
So I mean, escalation is the increase in material and labor through time, yeah. And you know, the unions are not going to ask for less money. They're not going to take a pay cut of $4, right? Or they're going to ask for $5 more. And that $5 more is going to go into the material cost, because now the material cost is going to cost more to actually produce. And then secondly, some of the material shortages were because of shipping. Shipping went up from $5,000 a container to $30,000 a container. Now that's coming back down. And because of some of these products, as you saw there, don't have too long a lead time, there is more flow coming through the ports. I mean, the port of LA couldn't unload ships, not because they didn't have any staff, because there was too many empty containers in the port. So the governor bought land in California to put those containers into a plot of land, and if nobody picked them up, he was going to put them in for scrap and give them to the state. So there was a lot of inconsistencies going on, and there was a lot of fluctuation in costs, and there was less workforce in the manufacturing units to be able to to produce the stuff which make the shortage, which then raises the price. Then you've got market conditions, which also affects your escalation. It could be anything between 4 to 7%, 4% here, 7% in LA, San Francisco. And there's all these economic charts that talk about, market conditions. My rule of thumb is when I fly into an airport and I'm going into a city, I count all the tower cranes and how many tower cranes that is, how busy that city is. I mean, in LA they had 50. The last time I came to DC, before the pandemic, there was 40. The cities are busy, or they were busy, and they're still busy. So I've answered the question. Oh, yeah. Do I need to answer it one more time?
So the question was, what's the root cause of long delays, and why it's continuing post-pandemic?
Post-pandemic.
Gary, talking about your tools your tool checks for estimate, which talk about the profile. Is there or are there limitations to using that for some structural work?
So the limitations of Deep Profiler are one, that you can't upload a model because you're doing this at an early conceptual stage. So we could even build a Deep Profiler model before the architect comes on board. So the owner may have a plot of land outside their facilities building and they want to build an MOB on it. They can come to us. We can get those criteria from the project manager and the owner, and we can build a model. We'll have a lot of assumptions in that model, but all those assumptions will be listed at the front so that when the design team and the contractor comes on board, they'll understand where we're coming from. So that's one limitation. I would say that's probably the only limitation because we can build everything else around it. One other limitation, if you bought it off the shelf, and it's from Beck Technologies, I couldn't remember that name earlier, Beck Technologies out of Texas, they don't have a database behind it. They'll give you RS means. So if I bought it off the shelf and I didn't have a database, I would throw it away because I can do a conceptual estimate a lot quicker with a piece of paper and a pencil. So that's probably the two biggest limitations of Deep Profiler. We've looked at a lot of softwares over the years, and we find this is the most easy to use and the best material for your buck, bang for your buck. Okay, with that, I'll pass it over to Gary Hamilton, who's going to do the Evolving Healthcare Design.
So I'm Gary Hamilton. I'm the USA Director of Healthcare for WSP. Been in the industry about 26 years. You said 30 seems long, like I just 26 years seem like yes, so I'm catching up. So I'm a mechanical engineer by trade, but fancy myself as a futurist in terms of smart healthcare, but and also a sustainability expert with respect to decarbonization and electrification. So what we're going to talk about is really how is the design evolving, and this is not only engineering; it's really wholesome look on design and what it is. We see that facilities are getting much more smarter. And that's technology. It's really digital, and how digital is making a play, how Internet of Things and is driving healthcare and AI, and all these type of technology that are actually coming together to really make the healthcare space much more smarter, increasing patient experience, and really increasing overall performance of your building and getting a better idea of what your building should be doing without human intervention. So touchless technology is something that came about and really was a heavy part of the response to the pandemic. It's really figuring out how you can enter a space without touching. It's really how you can enter an elevator, with the destination elevator, and a lot of technology that I'm going to show you some example in the next slide. What are owners looking at? More negative isolation rooms are something that a lot of owners are examining how they can actually get this and be flexible to get more if we do have that situation with a pandemic in the future. The expansion of telemedicine. Telemedicine became the greatest way of actually having access to healthcare during the pandemic.
And that, there was a large rise. Obviously, it really died down a little bit, but it's still on a trend in terms of accessing a great way to really take care of a lot of patients and a lot of healthcare needs. Switchable ICU and universal rooms are something that's coming back to the fold. I know there's a cost implication that usually deter a lot of owners from doing it, but it's something that's been done now. Enhanced filtration and enhanced ventilation system. This is something that all owners that I've dealt with are doing. It's looking at how you can make your system much more efficient. How can you improve the quality of air for your patient in the space, and how can you at all times reduce the possibility of spreading any airborne type of bacteria or virus within the hospital space. And lastly, but surely not the least, the medical gas infrastructure. We found out that the design was efficient in terms of how we designed it, but we found out that the actual infrastructure and the mains for the medical gas supply just wasn't large enough, to handle all the ventilators that was deployed during the pandemic, and that's something that we have to address. It's going to be difficult to address this in existing facilities, but all the new facilities that are designed, we're adding much more diversity and making sure that we don't experience the same thing going forward in design. So these are just some of the technologies that we have in terms of touchless key entry, as I said, but destination elevator control, and automatic sensors for touchless control. And even, we already use it a whole lot in terms of your faucet control within your toilets and stuff. And these are just a subset of what we have so far. So let's talk about smart healthcare and what it means. Smart healthcare means different things to many different people. That's the thing. So there's really no perfect definition of what it is. What is not is, it's not digital healthcare. It's not just having a digital system and because it's digital, it's smart. Because you could deploy all sort of digital system within your hospital, but it's still not smart because it's not talking to and using those, those sensors and points to do something with it. So what this shows, it shows, the traditional healthcare system, which is a series of silo systems. So there's biometrics, clinical administration, elevator, access control, energy management, critical, everything. It's all silo. It's all maintained by different people, or maybe by a number of different people, but it's all supplied by different manufacturers as well. So these are a lot of duplication on many things, on sensors and all those stuff. But what smart healthcare does, it's really, what it does, it's able to integrate multiple systems, and sometimes even running everything on a single IP network. So it's an internet protocol network in which you have maybe 2 cables or 3 just running the same and running most of the information on the same network, and really utilizing a whole lot of the sensors that are duplicated in many systems to really talk to each other. And it's really a way to really collect a whole lot of data points as well, and really figure out how you can use AI to really formulate some smart decision from these data collections that you have. Important part of this is obviously making sure that your system is secure, and that your cybersecurity response is also taken care of when you're doing this as well. So these are something that we're actively doing in buildings now. And what it is also, it's something that owners are trying to figure out, how can we price this, because it's really unknown. I think Penn Medicine is the newest hospital that has a smart hospital and are talking a whole lot about it. WSP has been doing this. 5 years ago we did the first one in China. We have done 2 in Australia, and we're doing the Leeds hospital for the NHS system in the UK as we speak. And the NHS has deployed a whole smart hospital guideline that they want. They want a whole digital entry to their hospital. So it's something that individually we're dealing with, but in the UK they're seeing it as something that's a response to how they're going to handle the future, and really how they're going to really make sure that the patient have a better experience. Their operations is much more optimized, and they're including a digital platform as part of their response to improving healthcare outcomes. So this is the Children National Telemedicine Command Center. So this is what you're going to see much more in smart healthcare and smart hospitals. You're going to have a control center because you're going to have a means of really visualizing all that's going on with all the data points that you're collecting. And what we were able to do is to work with children, and these are all biometrics connected to all the children beds and everything, and all the information is actually fed back to the central station that you can monitor and really the shortage of providers, it's a real challenge that we're going through as well. So they can utilize this to improve healthcare outcomes and really trying to respond to the challenges that they have with really hiring more providers.
Where is that at here?
This is at the Children National in DC. So this is brand new, maybe about 6 months old, that we've just done. So one of the things that that clients always ask, so who does this? Is it a manufacturer that you sit with and figure out what your hospital should be in terms of the technology and how to make it smart? Our response is that we actually have an innovation advisory group that's separate from our engineering group, but we work together in tandem. And we recommend that they sit at the table day one with the owners, even before the design phase is taking place. We talk to them and interpret their vision in terms of what they're trying to achieve, identify all the KPIs, and then we'll sit down and we'll basically give them some a specification and really some guidelines of how you should design and how it should be implemented before you go to the design, and you have that person as an integrator sitting through your design also. So that person is a part of the design team that helps you to really achieve the goals of your smart healthcare and smart hospital. I wanted to depict this because something that we discovered during the whole pandemic, we're really trying to figure out how to respond to the many calls for facility managers and how we can we can modify existing system to make more negative isolation room. And we were talking to our counterparts in Hong Kong and asked them and said, how are you doing this? Because at the time they were experiencing less infection and they seemed to be handling much better than us. And what I found out is that in 2003 they had, prior to 2003, before SARS, they only had 90 isolation beds in the whole country. And after SARS, from 2004 to 2019, they decided that we're going to really 10 times we're going to provide 1,000 instead of 90. So they basically went back and improved they increased the amount of isolation rooms, negative isolation room they have, because they didn't want to, obviously SARS didn't hit as bad as COVID, but they didn't want to go to the situation in which it's needed and they cannot get it deployed at the time. So they were able to to respond much better than us. And if you think about the most of the healthcare system here and the hospital and the beds, is that you have maybe 3 or 4 isolation room for 100 beds system. It's not a lot. It's something that is not something that we did. We were innovative enough to really create a whole lot of mass negative isolation room during the pandemic, but that's not the way to really handle something that we think that's this serious and can have such as a serious impact on life and on the livelihood of people. So their future, and that we talk to them about their future and what they're saying and what they're doing now for 2020 and beyond. They're doubling the amount of isolation room as a response to say that, we don't want to experience the same challenges again. So they're acting way before, which is something that we're doing. I don't think that we're as aggressive. Obviously, we're going through a lot of cost challenges and implications, but we're still trying to address it in some ways. This is just a switchable isolation room and something that we can do for existing facility in which Mount Sinai did. And initially you can see that's only 6 that was on a patient floor, and they were able to innovatively provide 48 on the floor by just adding some exhaust fan through windows and really using pressure sensors to monitor each room to make sure that they're negative when needs to. And these are switchable, so they can be, they could switch to negative isolation room when needed. I wanted to go, geeky and show you a full engineering diagram of air handling unit systems, but the intent here is to show that this is what the existing air handling unit system look like. You have an air handling unit in the hospital. The blue line is the supply air to all the space within the hospital, to the patient room and everything. And then the green line coming back from the space is the return air that comes back. So all the air that goes to the space is returned back somehow. So what it is, you have all the contents of the air, the bacteria, the viruses, anything that's within the air basically has to go back to the air handling unit to be filtered, and then you supply it back to the space. During the pandemic, one of the most creative solution that we had was to convert most of the units, if we can, to 100% outside air, meaning that all the air that we bring in from outside, we basically just throw it back out when we're finished with it. So we didn't take it back to the unit to filter because we were scared as hell. We didn't really understand, how this pandemic, how this COVID virus is distributed within the space. So at that point, we just said we just want to get rid of everything. We didn't even want to do any recirculation. So that's what we did. So what this is showing, this is a normal mode of operation, and what I'm going to demonstrate to you is that you see where that X is. What we've done in many facilities now, we've added an exhaust fan system, full exhaust that can do 100% exhaust. Some hospital couldn't do the 100% outside air at the time, but what we're doing now for new design is that we're up in the design and we're creating a whole complete exhaust system with redundant fans, so that if one fan is down, the other fan will be able to run to exhaust the air from the facility. And really what you're doing is you're actually just removing this closing off a valve. So the X is really closing off all the return that's going back to the unit, and you're converting the whole thing in 100% outside air, and your fan is activated and you're exhausting all the air outside of your building. And this is a great thing to do because in normal mode, you're using the normal amount of energy. Obviously, during this mode, the energy use is is going to be 20 to 30% much more. But what it is that you're preparing yourself for any airborne type of pandemic or airborne type of challenges that we can have in the future. So this is something that we're deploying and use for many projects. What are the implications? There's a cost implication, because what this means is that your cooling is going to be much more amplified. And what that means, the cooling actually, your chillers burns the most electricity in your building. So what this means is that your electrical gears are going to be bigger than what it usually is. So your generator is going to be upsized, your switch gear is going to be upsized, and your cost is going to be about 15% more than what it should be. And these are some of the unfortunate challenges that we're going through in projects in which owners want to do it, but when the price come back, they're trying to figure a way out how can we do this, how can we achieve this much easier. And these are some of the questions and some innovative ways that we have tried to, we're trying to figure out. And some of the things that we've done is even looking at using HEPA filtration as a means of not going a full 100% outside air. So what we do, we design the unit with the ability to add HEPA filtration sometimes if needed in the future. But you have to size the fans and everything to make that happen. But it's possible because now you have fan arrays in which they can ramp up and ramp down and really be effective in terms of design. So this is just some excerpt of some of the stuff that we're doing. There's also, we talk about decarbonization, but electrification is one of the most important technology that's going on, and really electrifying healthcare system is going to be something that we're going to be talking about for the next 20 to 30 years, because 2050 is coming in terms of net zero. A lot of companies and facilities are pushing for 2030. We just had COP 27, 28. Net zero and energy reduction is something that we have to concentrate on. And a lot of office buildings are being fully electric now. And we've also just designed our first electric hospital in UCI Irvine in California, which is something that WSP is extremely proud of. And we could, it's still in HCI approval now. Oshkosh is changed to HCI, as you know, it's California is very different, but it's possible. And it's a fully electric, including considering electric equipment even in the kitchen. What we found out is that we thought that this would be maybe a 15 to 20 year payback. It's actually a 3 to 5 year payback, but that's in California. So it depends on the weather and the temperature. And what they're using is heat pump technology. It's really just taking the heat from one space and basically put it in another space that's needed. So it can be a water source heat pump. It can be a ear-to-ear heat pump that they're using to achieve that, heat pump chillers. So all sort of cool technology, but it's truly possible, and that's something that a lot of owners is going to be able to figure out how they're going to implement that as part of their design. One of the biggest challenge again is the grid. Is why would we electrify when you have a dirty grid? That's something that the country and we have to think about, and we have to think about going forward and how we're really going to respond to that. But it's truly possible, and it's going to be in much more hospitals as we go forward. So, any questions?
Question about the Hong Kong hospital. I was wondering if they actually measured outcomes against similar hospitals that did not have isolation to see what or maybe you mentioned that, but were the outcomes that much more positive for the patients in the isolation where they had all the isolation rooms? Yeah.
Yes, and that they basically did a post-occupancy evaluation and really look at how the system works and why it works, and are using that data also that's how they validate even doubling the what's required, because obviously it wasn't a situation that they just designed and was, SARS didn't really give them any experience. It wasn't widespread, so they weren't able to really test and really figure out the success of doing it. But they have data to prove that it worked, and that's the way to go. And that's the reason why the UK has adopted the same thing in terms of the NHS, and we're doing some healthcare system here are actually doing the same thing with respect to the response as well.
Good job, Gary. For the AHU design that was shown for the supply and return, that pandemic mode, is that now the accepted way of doing designs?
Yes.
Okay. And what's the markup? What's the additional cost you're seeing to adapt this process? 15%?
Yeah. Yeah.
I have one more. All I go back and forth. Back to the first part where you had the technology and the integration. Where do you think the greatest challenges are in terms of actually integrating the systems? Because I see building codes, I see manufacturers not talking to each other. Where do you think those are, and how do you break through those?
And it's funny, you knock it at the head. It's code requirements and manufacturers, because what it is, and if I go back and just to demonstrate the challenge, all these systems have to have a mechanism in which they communicate. So if it's Bluetooth, if it's Z-Wave, they have to have a communication technology, and they all have to have the same thing if it's not going to work. So these are some of the stuff that, and I think the Penn Medicine in the U.S. is one of the most successful now because they did deploy all the system to have a similar communication technology where they can share those data. So that's one of the things that we have to make sure. One of the things, it's going to be a huge challenge because if you're a not-for-profit system in which you have to you have to have 2 or 3 different vendors, to as part of the competition. It's going to be a challenge in some way to really have multiple systems that could actually do the same thing. So the technology has been improving. So you have multiple manufacturers, more than one for each of the technologies. So that's one of the challenges that we have. But also one of the things that we have to really figure out is really one, how do you price this? It's one of those things that, and how smart you want your hospital to be, because you can say, okay, I only want half of my system to talk to each other because I really don't care about my voice over internet or my nurse call. I want it to be standalone and because my whole system is using this, and I don't want to use it because don't have the digital technology to talk to all of these stuff. So those are just some of the concerns that you can have going forward. But one of the important response is really having someone or having a designer or integrator that understand and can interpret a vision of an owner and really articulate that vision into some KPIs that you can bring forward through the project, and that person will sit and really shepherd the whole team through the whole process of really getting that done. And this is not something, it's healthcare, we're a bit slow on this, but airports, they're doing this, and many office buildings, they're doing this, so they're doing this everywhere else. So it's not something that's completely new and novel. It's something that basically we just, healthcare really, are kind of, the turtle when it comes to technology. And we, because of codes and guidelines, we really take, much longer time to adopt these type of innovative ideas.
The mode of, what's that? Sorry?
Pandemic mode.
The pandemic mode, thank you. And pandemic mode where you exhaust the return air outside. Now, is there no way, no technology to rather purify the air and reuse it instead of exhausting it to the atmosphere?
Yeah, yes, and that's why I mentioned using HEPA filters, because even when you exhaust,
Not filter.
Yeah, purified.
Filter.
Oh yeah, well, there is a lot of technology that, it's UV technology in terms of UV sanitation. There is ionization, airborne ionization that that can be used. But these are stuff that was sold a whole lot during the pandemic. But as far as I'm concerned, I can't recommend or say these are complete solutions without having data to really prove that these stuff works. There's some of these technology they do have laboratory data, but to actually have some post occupancy evaluation of these systems, I think we need to do much more study on it but for us, we think the tried and tested is really to do exhaust with HEPA, but airborne ionization is something, and UV is something that we're using. We use UV lights on a lot of air handling units. Firstly, we use it to kill bacteria and viruses on coils, but you can enhance the light also to really treat the air as well, and really have it as a means of protecting your air system from bacteria and viruses.
Great presentation. Thank you, Gary. I'm going to tack on to Adrian's question and Alton's question over here. On this slide on smart healthcare facility design, you were talking about how it's hard, like for a not-for-profit system, to get competition if we need that. But the flip side of that also is that, I want to make sure, I don't know who's in the room, make sure I say this correctly, is how do we get to where if all of that stuff is controlled by one software or one system or one company, that they don't then own us? Because we sort of get in that situation with some of our other systems on campus, and it is a concern.
So it has to be, any system that you choose has to be a truly open protocol system. That you literally, as long as it has the communication protocol, you don't have to, it's not like you have Johnson's Control or Siemens or Schneider as one system and you can't do anything. Anything you come, they're gonna, you're gonna get charged to implement every bells and whistles, and you're gonna be, and it's one manufacturer. It has to be a situation in which you don't have that manufacturer, none of the manufacturers at the table at the start of the project. And I could tell you that I've seen where it's done wrong. And even, with Penn Medicine, they didn't really have an integrator. It's a situation in which you want to have somebody integrated that's there. And if that person has to be agnostic in terms of the type of kits that they're choosing and type of digital device and the type of system, that person need to be unbiased when it comes to that. But it has to be an open protocol, a truly open protocol that it could speak to many. So if it's a Siemens system that you have or a Johnson's Control system, it still could talk to the ICT that they're using for integration. So that's one of the things that it has to happen. And more manufacturers are coming together also and to get that done. So they understand that the only way to achieve this is to really come together. So they're doing that. So that's something that they're actively doing.
Fascinating discussion about cost, about the amazing things that are happening in hospitals in the future. I think what we're going to talk about, what Paul and I are going to talk about over the next hour or so, is how to manage those processes when you have all the complexities that Gary Hamilton talked about and all of the financial pressures that Gary Bratt talked about. So we're going to focus on a couple of things. We're going to focus on looking at best practices in terms of managing projects, managing project processes. We're going to look at program management office, what kind of systematic approach can you take to looking at managing these top 25 things that are out there. And then we're going to dive even further into the details, and Paul's going to talk about project management guides and what that looks like, the tools, the examples, the results that you can get from having a comprehensive project management guide. So we're going to jump right in. Over the last 20 years or so that Cumming has been doing projects for healthcare systems and hospitals, we've pulled together a list and project processes for about 30 different hospitals and healthcare systems. We've used that information, that along with interviews of not only the directors of planning, design, and construction, but the CFOs and the chief administrative officers, and we've said, what's the most important things that you see in terms of making projects successful? We pulled this data. We have 30 plus project process guides, policies, procedures, and we extracted out of there what we call our top 25 best practices in terms of project delivery. I'm going to go through kind of 3 sets of these. We kind of group them into different arrays, if you will, of that information. So the first is kind of the idea about purpose and strategy. And so a lot of this is related to kind of the start of the project. We're not into design and construction yet. We're really into kind of what that process, how are we setting this up? How are we integrating with the organization as a whole to make sure that these projects are successful? I want to point out a couple of things that are, all my things I point out are going to be related to what Paul's going to talk about next. So we cheated a little bit. So I think the 2 and 3 kind of you may see really go together in terms of an understandable and flexible process and clearly defined vision in terms of what the outcomes are going to be. They may sound similar, but I think from my perspective, they take on some different mantras. One of the fun and interesting things in looking at project management guides across all of these hospitals and healthcare systems is that some of them are like this thick and some of them are like this thick, right? And when we looked at the difference between the two, no offense intended to anybody, there was one similarity, there was one commonality with respect to the process guides that were thicker than 10 phone books. And that is that a lot of those individuals, those VPs or senior VPs of planning, design, and construction that put those books together came from the military. So whether you look at a Banner or a Dignity Health, a number of examples that I could give you, all of those organizations were run by somebody that came out of the military. Not bad, not good, just that they were very process and very detailed oriented. And the healthcare project management outside of the military doesn't necessarily need all of that detail. And when you get that much detail, you get project managers that get despondent from having to check the box on everything, as opposed to really think about how to manage projects. And they are the ones that that we don't want to lose in terms of having that understanding of what's going on there and being engaged. Just an interesting side there for sure. The vision for the project, from my standpoint, the purpose and vision, really involves what are the deliverables for that project. I've seen time and time again when a major healthcare system allocates $300 million to build XYZ hospital, right? How many beds are there? What are the things that are going to drive the revenue that are really integral to getting that approval from the C-suite, from the board? And I think as we see, unless that is an integral part of the vision for the completion of the project, it's something that a lot of times gets lost, gets mired in the details of wanting to build something that's architecturally significant, or something that has sits on a particular piece of property or something like that. So I think those two things are really key in terms of key examples in terms of what are very important aspects of project delivery from a purpose and strategy standpoint. We go next to scope, schedule, and budget, as was one of my mentors explained to me. It's all about scope, schedule, and budget, right? So you have to understand what the scope is. You have to understand what the schedule is to be able to have Gary, Brett effectively and efficiently run the project. Run a project budget, whether it's with DProfile or with his pencil and paper, like he used to do. A couple of things here that I think are really important and that really kind of hit some of the key things that don't always get looked at, right? And the first is number 12, is kind of that identification of risks. So we always have this idea of, okay, we've got X amount of escalation that we think we're going to have. We have X amount of maybe owner contingency or contractor contingency. And I'd propose that we really look at a risk registry that identifies all of the risks that I kind of call known unknown risks. So you have the concept of known unknown risks, where you have underground, where you're digging in foundations. We've all had to do that before. We've all found something or crossed our fingers and not found anything, right? We also have this idea of unknown unknowns, which is really what we want to allocate kind of that percentage contingency to. The unknown knowns are things that you can find in the contracts. There are things that you don't know about the site, that you don't know about the municipality that you're having to deal with. You don't know about some of the design aspects that you want to create in there. And those are things that you should really identify those as risks in your risk register and put dollars to them, right? Put dollars to what those things might have an impact towards. The beauty about that is as you march down when you do that, and you're not just using a percentage, when you march down the project from a schedule standpoint, you can kind of check the box on some of those things. When we're out of the ground from a contingency standpoint, we had $600,000 in there because we might find contaminated soils, right? As we're out of the ground and we're starting the superstructure, we can check that box and we can take that $600,000 and start to look at where we can allocate that for other things. One of the other things I want to talk about, and a lot of you guys do this, right? It's not rocket science. It's something, but it is something that we saw, that Paul saw in his last assignment in putting together a project management guide, in that they didn't have a systematic approach to hiring architects and contractors, consultants, anything else, right? I mean, it's not only the contracts in item 17, but it's the process that you get to make those selections that really are kind of key. Again, they kind of go together a little bit. But it's amazing how often, just last month, right, that we find that there's not that process in place, and that's one of the easiest ways to be able to kind of help understand what some of the risks are that I just talked about as well. All right. Last is kind of overall process and a good transition to what Paul's going to talk about. But I think one of the key ones here really is talking about document tracking. We all kind of should have a document tracking system where we have everything that's in place in one place that we own, that's accessible by us at any time, at any place we want. That's hopefully, if we don't, we talk with Gary about how to get it, because he's our technology expert. The other piece I think for sure is that's maybe not something that you see every time, but it's the performance tracking. So we're not talking, in performance tracking, we're not talking about a monthly report that shows a couple pictures about what the project looks like at this point in time. We're not talking about, how much money we've spent and what we've spent it on. We're talking about looking at a baseline from a schedule standpoint and from a budgeting standpoint, and really seeing from a budget standpoint, where are we at with the cash flow? Are we at where we thought we were going to be at, or have we spent a lot less than we should have? That's an indicator of a project being late. Same thing from a schedule standpoint. If we look at the schedule, one of the things that a good scheduling report does, when you think of schedulers, you think of, okay, this is the scheduler that puts together this 3,000 item schedule, right? That's not where I see value in terms of scheduling. In terms of scheduling, I see value of evaluating how many activities were supposed to start in the month of January, and how many activities were supposed to finish in the month of January, and how many actually did. Because then again, you get an indication of where the project is at from a performance standpoint, not just kind of a reporting standpoint. And that's really valuable for you, because if you're like me, almost every person that I ever talked to has always had a project where the contractors said, oh yeah, we're going to finish on time. We got it, no problem, right? We'll be done in June 30th, no problem at all, right? And you get to like June 1st, and then they come back and say, oh yeah, we're going to be 3 months late or something like that. And that may be bad for the contractor, but from an owner standpoint, I've sat in your shoes, it's incredibly disconcerting when that happens. And the ability to be able to kind of call the question when you see some of these statistics is really important. I'm going to shift now a little bit off of the top 25. By the way, everybody that's here, we're going to send out the top 25 list and kind of a little bit more on each one of those. And so you'll be able to have the list. It's something that we're going to provide to you as part of coming here for sure. Use it with your PMs that work for you and your staff that work for you. Use it with your C-suite, however it makes sense. Hopefully it'll be of value to you. So we've talked about all these 25 different things that probably equate to all 100 different processes and stuff like that. How do we kind of get our arms around all of that? And the way that we've done that with healthcare clients, non-healthcare clients, is to help them develop what we call a program management office. And that starts to aggregate, again, not rocket science at all, but it starts to aggregate all of the data from, not unlike what Gary was talking about, is aggregating the data from a building, starts to aggregate all of the data from all of your projects into meaningful buckets of information so that you can start looking at what you do, for example, from a post-occupancy evaluation. What are really nice things that the customers, that your end users, that your members, if you're Kaiser, are really liking about that building, so that you can duplicate that and replicate that in the next building. And the things that they don't like, you can not do in the next building. So really kind of that idea of enhancing customer or client or member satisfaction by identifying in aggregate from every project, and again, statistically, the more data points you have, the better off you are. One of the other pieces for us, for sure, I've already mentioned it, that risk, the idea of if you've got things that you can look at from a past project or past projects that have automatically been a risk for you. There's a big healthcare system in the western half of the United States that, I bring that up because it's not the east, in the western half of the United States that has a very, very onerous contract, right? And they end up in litigation or in arbitration on almost every one of their larger projects. And when we work with them and we look at them and we go talk to them, I was hired by the CFO to say, why do we keep getting into this situation? It is specifically because of the fact that they're trying to shift too much risk, more risk than legally they can, from the owner to the contractor. And I had one of the CEOs say to me, which was kind of a funny comment, was, gee, and we came in after and we looked at this contract and we said, this contract's too good to be true. It says that anything that the inspector asks for, the contractor's going to pay for. And the CEO said to me, gee, I think we had somebody that was too good of a negotiator when they negotiated this contract, because that ended up coming back and was not enforceable, and the owner had to end up paying money when they thought they weren't going to have to. So value of a project management office to kind of roles of the project management office. And I think some of those roles are really, or all of these roles are kind of really aggregating some of that information so that you and your team can deliver the next project better, as opposed to, what we see all the time is just project manager going in there and doing what they did on their last project, whether it was successful or not successful. The idea kind of all the way at the end of the continuous improvement of what that process that you're using. When we put together project management or program management offices, it's not perfect, right? We might not do all of it. We might do a piece here, a piece there, But the idea is that you're going to take what gets developed and you're going to improve on that every step of the way. We have PM guides that Paul's going to talk about, where we have identification of changes that they want to make in that PM guide on a monthly basis that get evaluated and get incorporated into that PM guide based on experience that the project teams have. And not just internal project teams, but outside project, contractors and architects as well.
We're going to start digging into what a management guide might look like. And some of you probably have a lot of these tools in place. I know some of you do. And so I don't want, I'm open for discussion about what works and what doesn't work. But, here are all the attributes of why you want to have a project management guide. Consistency, common languages, process, tools, templates, and checklists. That's a big one, and we're going to get into that quite a bit. But you can see it's almost like common sense that these things would be better and enhanced as you have a management guide that focuses on these areas. To produce a project management guide, we've seen a couple of different approaches in how you get started with it is very important. And I just raise a flag here that you really want to look at the culture of your organization, the team of project managers you have, and understand what is going to work for them. Communication is very important as you go through this process to obtain feedback and loop back as to what the actions are from that feedback. And what Bill has been saying about the very thick project management guides that don't get used, would recommend that if you're starting something new with this, you look at a phased approach and focus on those things that can be easily developed. A couple of ways that I've seen this done is with consultant assistance, obviously, and an in-house approach. So I'm sure you guys can take care of that, right?
Saying a lot of bad words right now.
So there's pros and cons to both. If you bring in a consultant, obviously there's a bit of a learning curve. If they don't know your organization, they have to understand how you operate, what you have, what you don't have. But then a consultant can also bring in experience, such as standard contracts, checklists and tools off the shelf that have been prepared for others. In-house approach, we've got Adrian here from Kaiser in the audience, and he's done a very good job of creating an in-house approach for project delivery guide, is what they call it, in terms of actually asking the staff to work on these guides and develop the processes associated with the guides, and then doing a peer review with the project managers and team to make sure that what has been put in the guide is applicable and appropriate to the way things are done or should be done. Of course, you have to worry about your resources and where you're pulling these people from and how long it's going to take to get it done. So what I'm going to go through now is the sections that we have used in a project management guide. So section 0 talks about the purpose of the guide. It really identifies where you're headed, why you're doing the guide. And the bottom number there is really important. As I mentioned with what Adrian had done, they had an individual that was responsible for the guide. And so it served as a gatekeeper as things were developed for the guide. So we'd like to have an owner for the guide as soon as possible that can manage the process going through it as well as what happens thereafter. It's a living document, and so there will be things changing. Section 1 is general planning, design, and construction operations, roles and responsibilities. A couple things there that that Bill had talked about, the preferred provider network, standard contracts, having that procurement process identified so that you can go through it on a consistent basis from one project to another. And then I'm going to get into the PM systems a little bit later on. But we also, at this point in the guide, we develop a work plan template. We have a work plan template that we use, and that carries through all of the different phases and gets updated and approved at each major phase or milestone. Standards and design guidelines. When you want to prepare a guideline, it really refers back to a lot of standards and guidelines that you may or may not have. And we think it's important to be able to point to the types of the methods that you use to deliver projects. Patient experience, sustainability, diversity, safety, all very important elements of a guide that we like to point back to as metrics in terms of what you want to accomplish with your projects. Project processes is in section 2, very important section. So section 1 and section 2 really have a lot of the meat in a lot of the guides that we've developed that you refer back to as you're going through the design process. So there's the approval process, team charter, that's very important. Support partners, we'll talk a little bit more about that. And then, of course, budget and schedule that gets put into this work plan at the very beginning so that you can update it at the end of concept scoping, SD, DD, and CD. And that, that's we've got up there phase 1. That's what Bill was alluding to in terms of at the beginning of a project, really making sure that you've completed a phase 1 due diligence so that you can seek approval and use that as your guide going forward into the other phases. Sample of a project charter, team culture values, the vision for the project, and then goals for the project. I'm a big fan of these charters because it really gets people on the right page at the beginning of a project. Obviously, if it's a small project, you may not need it, but even with a small project, you definitely need to know what your goals and objectives are. But it's really good to sit down with your team working on these projects to really have this discussion about these important elements of the project. And then, of course, what I refer to as project support partners that are very important to the success of a project. IT, anybody ever have any problems with IT? Engineering and maintenance, definitely need to involve them as soon as possible. All of these are very important partners in a successful project, and we built into the guide that you contact or there's an open dialogue at the major phases of a project with these folks so that everybody knows where this project is headed. Phase 3 is the design phase work, SD, DD, CD. What we have illustrated up here, which is pretty helpful, is a list of the minimum requirements at each one of the phases. So that as a PM, I can look at this list and say, oh, got that, got that, got that. No, we don't have that. So it's a good checklist as well so that a PM can look at it to make sure that what you ask for in the CDs is what you want. And again, Bill talked about cost and value analysis and the risk analysis. I think a lot of times we don't give risks a lot of forethought, and then if you get your team to have a risk discussion, you might be surprised as to what comes out of that discussion. And then again, approval at each phase, which might be the end of each one of the major design phases, or it could be a specific project milestone, a board meeting, leadership meeting, or update that's required. Let me get into some template examples. These are templates that we recommend for inclusion in the project management guide. They're things that your project manager can pull off the shelf, and they have a template they can follow to fill in the blanks. It might get them thinking about certain things that they may have not thought about before. Example of that is the work plan, executive summary with those items in the work plan. And obviously, you can cater this template to what's important to you and your leadership in your organization so that at key moments in a project, they get the right information that they're looking for. Checklist examples. One client we were working with, first time I met him, he said, "Have you read the checklist manifesto?" Former military guy. And so, of course, I read it, and it's a really good book. So we've identified a lot of areas where a checklist is really a valuable tool that a project manager can use to make sure that things are getting done. We've got the cost analysis log there. We've got budget, schedule, work plan, different checklists. I think we probably have, in this particular guide, we probably have about 13 or 14 checklists. The next sections, 4, 5, and 6, follow pretty much the same routine. You know, construction and closeout obviously get a little bit more complicated. And I think there's a lot that you can cover in a closeout that doesn't necessarily get covered. And so, you know, when you're looking at developing a project management guide, you get some good thought as to what the elements should be in a closeout package. You know, as you consult on these project management guides, it sometimes feels like you're a therapist getting people together to talk about how they operate and how they should operate. And it's amazing, you'll get the same group of people that have worked together on a daily basis, and they all have a different idea as to how they do things. And so it really helps to, and closeout is one of those areas. It doesn't necessarily get defined all that much. And then, of course, construction is a pretty heavy part of the guide, gets into a lot of the details of managing a project during construction. So I didn't want to take too much time on that. And of course, entitlements and permitting is an excellent place for a checklist. I want to share with you a couple of examples. These are organizations that we've completed consulting for developing a project management guide in a program management office. This is one that's currently in progress. So you can see here within the guide, you can click on a section that is referenced within the guide, and it goes to that section. It's running a little bit fast. You can click on an exhibit, and it'll take you to that exhibit where you can download, you know, this work plan outline. So that's one example that is a little bit bare bones. This one is the Coming PM playbook. It's a little bit, you know, it's got nice graphics, and it's got a good way to maneuver. So you click on these tiles, and it jumps you to different sections of the guide, and then it'll jump you to the exhibits as well that you can download and use for your project. You can see it got downloaded. Last slide, and I am by no means an expert on these things, but part of a valuable tool with managing project is to have the right system do the right things for you. And I don't know what a lot of these systems do. I'm familiar with some of them and use some of them. But it really requires a lot of thought, and Bill and I are going to start a side business of consulting on what systems they should be using. And so this is a build diagram here that talks about the guide, the PM software, and document control. And I think you were referencing one client that had different systems that really focused on those areas. And then, of course, integrating with your GL ledger system is also an important aspect of this. So that closes that. I'll ask for any questions, discussion.
So does the size of the organization, complexity of the organization, how does that play a part into the size and complexity of a PMIS manual?
That asked you to think about what's going to be most effective for you in your organization. That's where size would come into that discussion. One of the organizations we're dealing with is a part of a big system, but they're approaching a project management guide on their own, so to speak. It's like a 2-hospital system, kind of small. And they called us in because they don't have anything. They just hired a new VP in charge of design and construction facilities, and there was nothing available for him to refer to help his project management team. And at that time, he didn't have any project managers. He now has 2, and he's mandated that they use the guide, which is great. And they are looking at it and using it, and of course, they're coming up with a lot of questions and potential improvements. So, do you have any additional thoughts on that?
So how does it change if you have internal or external project management? And with external project management, it may conflict with their company's processes. How do you bring those two into alignment so that it meets the owner's needs through that process?
Well, I would encourage you to find the right contract project management group that offers you what you want. If they don't give it to you, then number one, identify what they should be doing that they're not doing, or identify what you want them to do. And then obviously within house, that last example I mentioned where the VP said, you need to read this guide, and you also have to read the checklist manifesto. And he hired new PMs, and so they are heading in the right direction in terms of following standard operating procedures. So that's a small organization. I'm trying to think in-house versus out-of-house project managers and how you can apply this. I would hope if you're using consultant project managers, they're able to bring this to the table. And if they're not, then ask them to fix that.
You did talk about tracking performance. Now, do you have any tool you could recommend to track performance from project inception to the construction closeout?
Yeah.
That cycle of the
We
project.
do have I'm happy to share that with the group as well. We have a set of KPIs that we use to look at tracking in terms of approval processes, et cetera. A lot of the PM softwares have those built in. Procore or an eBuilder or things like that actually have metrics that you can pull out of there if you know how to do that. But a set of KPIs to look at, every project's different, right? So it's hard to say, okay, we have to have, a set of CDs in 120 days for every project, right? So these KPIs are really based on looking at what project managers would need to do without being specific to a particular project. I'm happy to share that with you as well. Yeah.
Is one of those if your billing is falling short of what your budget is, that it might be a flag on the schedule.
Yeah, I mean, I think that's not necessarily a KPI for a project manager in-house or out-house. Sorry, maybe not a way to say it. But you know, that definitely is a KPI for a project. A KPI for a project manager would be, you know, are the billings going through in a particular time frame?
Right.
Our projects, you know, some things like that are really key to be able to look at to understand that, for sure. Yeah.
This is actually a combined question, which gets into what's the relationship of the program management office to the project manager?
I was hoping somebody would ask that question, right? So the nice way to think about it is that it's a symbiotic relationship, right? So you have project managers that are out there running projects, and you've got a program management office that is evaluating how well those project managers are running those projects, right? So it's a little bit symbiotic, and it's a little bit, you know, kind of conflicting because the project manager wants to go out and run the projects their way, or has particular aspects of the project that maybe the PMO doesn't necessarily understand from an evaluation standpoint. And the PMO is trying to understand what the best practices are and help instill that in the project managers themselves. So symbiotic, maybe a little tension there. I think that's a good thing. It's a good tension because you want to be able to hold everybody accountable to best practices, but you also need to understand that each project manager, each project, as I just said, is different, so you can't necessarily do that with a heavy hand.
And I'm going to pile on that question.
Yeah. You did say it was for both of us.
I'm not going to answer. I'm going to ask you another question.
Oh, okay.
So that symbiotic relationship and having, I don't want to say dedicated resources for a PMO, it kind of makes me believe that that's a larger organization.
Yeah, I mean, yes and no. To the point about, you know, is this scalable? It's 100% scalable. I think the idea that you can do a lot of what a PMO can do through technology, and we're not talking about just adding a whole bunch of people. You know, we got 20 project managers, we got 20 people sitting in the PMO. I've seen PMOs as small as one person that is collecting that information using a Projecto or a eBuilder data, right? And I've seen them as large as, you know, 10% or so of the project manager. So, you know, I think the idea of collecting all that information and being able to create metrics and understand how the program as a whole, the capital program as a whole, is being ran is a really important tool. It's as important, well, maybe not as important, but just as important, as what Gary does in terms of collecting all the cost data and creating a database of costs for you so that you have a better understanding of what to budget for the next project. In this case, you have a better understanding of how to deliver the next project as well. You can do both. And back to your question, I just want to kind of tag on, if you will, from a outsourcing PM to an insourcing PM. It's your PM guide. It's your process. If they're coming in there, they're using your process. And we see that a lot of times. You know, there's always this idea of you have, you know, this much steady work, and so you hire that much staff to be able to handle this much work. If there's a big spike in the work, you want to be able to have the idea of you can hire those people and then have to let them go in a couple of years, or for a more expensive amount of money, I'll grant you, you can hire somebody that has that expertise in that particular cancer center project, or can handle that project for a short period of time and then go away. This base number of project managers allows you to keep your institutional knowledge, but you're able to kind of flex, if you will, a little bit. But those project managers that come in, whether it's our firm or any other firm or for a particular project or a staff augmentation, they should be following your processes, not our processes. We use our processes, the ones that Paul was showing, when our PM guide, when an organization, whether it's healthcare or not, doesn't have any process. And we find that a lot.
Typically, when I see an owner outsource, and I've been outsourced in that situation, I think the owner, and sometimes it happens if the owner is large. I've seen this in a couple of different employment scenarios where the owner needs to be on the same page with what it's doing. If you're outsourced and you're getting conflicting direction from the owner, it creates problems for the owner and it creates problems for the contractor as well. And it generally doesn't seem to work out well for either one of them. And I just think as an owner, you need to be on the same page internally with what you're doing, with what you want. Just the same, even if you have an employment in-house, you still need to be on the same page, really regardless of whether you're outsourced or insourced. Whoever's giving direction needs to be consistent, that's all. And I've seen it where it's not, and it's not pleasant for anybody involved.
Great point.
Yeah, thanks, Doug. And I've experienced that where a local hospital is not on the same page as the corporate national system.
I've experienced that too, and I've also experienced it in federal government lines as well.
Yeah.
I'm going to sit down and let Michael and Paul finish. Send us out.
I was going to thank Samuel for bringing you down.
I just wanted to make note that one of you just mentioned that if the local facility is not on the same page as the system, that can create a similar conflict. And I just want to note that, I mean, I know it's not just the system I work for, but this is a very, very common problem. And this is a very common problem that we actually do expect our PMs to manage. So if your client is the system as a PM, but your internal customers include local leadership that you have more frequent access to, maybe probably daily access to, that can really create a situation where you need to have that strong leadership mentality and team mentality as a PM, that you're constantly communicating with the system to let them know what direction you're being given and to receive direction back as to what route to take under what circumstances.
Exactly. Yeah. You get stuck in the middle big time.
Yep. We paid Sarah to be here.
All right. Well, thank you once again for venturing out and coming over to our office. It's been great to have you. It was really good to get the comments and the questions and start the dialogue between us all here. You know, that's really what we wanted to accomplish. So thank you very much again. Really appreciate you being here.